Imagine the rhythmic, almost hypnotic beeping of monitors echoing down a dimly lit hallway. It's the dead of night on a cardiac ward. The smell of antiseptic hangs in the cool air, and the nurse's station is quiet. There's this deep, false sense of security here. You wouldn't know it just by looking, but the fragile, totally invisible line between life and death, it's about to be crossed.
It's 2:17 a.m. Mr. Okafor is a 62-year-old man admitted earlier for a mild heart attack. He's been perfectly stable all evening. I mean, literally, just a few moments ago, he was sitting right up, chatting about his grandchildren. Now, there is an unnatural, heavy silence. He suddenly slumped back into his pillows. His eyes have rolled back, glazing over in the dim light. He isn't speaking, he isn't moving. Let's dive right into what's happening deep inside his chest. At exactly minute 0, a catastrophic microscopic failure is unfolding. A rogue clot has suddenly ruptured and formed a complete blockade inside a major coronary artery. The heart muscle, the myocardium, is entirely cut off from blood flow. It becomes ischemic. That means it is actively, desperately starving. And without life-giving oxygen, those suffocating cells are forced to switch to an emergency backup system called anaerobic metabolism. But there's a fatal flaw here. The byproduct of this switch is lactic acid. As this highly toxic acid rapidly floods the local tissue, the myocardial cells become incredibly unstable, completely short-circuiting their own electrical pathways. This severe electrical short circuit triggers a terrifying state known as ventricular fibrillation. Now, a lot of people assume that during a medical emergency, the heart just stops. But what actually happens is so much more violent. The heart is still moving, but it's completely chaotic and totally useless. Imagine hundreds of thousands of cardiac cells panicking, misfiring, all at the exact same fraction of a second. The thick, muscular ventricles aren't pumping blood at all. They are violently quivering, literally like a bag of writhing worms. In this state, the heart is just actively destroying its own rapidly depleting energy reserves, producing absolutely zero cardiac output. When you compare it, the contrast is startling. Normally, you have this beautifully coordinated, elegant electrical wave cascading down the heart, mechanically squeezing life-sustaining blood out into the body. But right now, inside Mr. Okafor's chest, there is complete and total electrical anarchy. The heart muscle is technically in motion, sure, vibrating wildly in the dark, but let's be perfectly clear about the grim reality here. The patient is already actively dying. Let's walk through the ticking clock of these first 20 seconds, because it's a terrifyingly rapid descent. 5 seconds after the heart stops pumping, blood pressure drops to absolute zero. The brain notices instantly. Consciousness is completely lost. 10 seconds in, if you walked into the room, you'd see him motionless, completely unresponsive. At 15 seconds, you might actually notice his chest moving, but the mechanics are entirely wrong. It's not a breath, it's a terrifying mechanical spasm. 20 seconds in, you press your fingers against the warm skin of his neck to check the carotid artery. There is absolutely nothing pulsing beneath your fingers. Total cardiac arrest. I really want to jump back to that 15-second mark for a second. To those deeply disturbing involuntary chest spasms known as agonal respirations. To a terrified family member standing at the bedside, these sudden guttural snores or gasps are incredibly deceptive. They desperately look like normal breathing, like hopeful signs of life. But they're not. These gasps are just a primitive reflex. It's the brainstem experiencing profound oxygen starvation, essentially making a final, macabre mechanical glitch in a dying body. They are actually loud, undeniable indicators of impending death. Now, you know what's wild to think about? It's just how relentlessly greedy the human brain is. Despite its small size, it consumes a staggering 20% of the body's entire oxygen supply, and it has zero backup reserves. None. So at this exact moment, the patient's greatest enemy is no longer the failing heart, it's the clock. Without fresh circulation, those incredibly oxygen-hungry neurons begin physically failing and literally dissolving. We hit minute 1. Someone smacks the blue button on the wall. Code blue, room 12, blasts over the overhead speakers. And just like that, the peaceful ward violently transforms. Doors slam open. The heavy crash cart is sprinted down the hallway, wheels vibrating against the linoleum floor. A team of 6 people surges into the tiny room, moving with hyper-focused, controlled urgency. And here is the deeply uncomfortable truth of this exact second. Right now, with no pulse, no circulation, and no effective heartbeat, the patient is a corpse. Clinical death has officially begun.
So how do we fight back? The sheer physical brutality required for effective chest compressions is just astounding. A provider interlocks their hands, places them directly over the sternum, and pushes down hard, 2 full inches deep. You can often literally feel the sickening sensation of cartilage separating from bone. The sternum violently moves downward, physically crushing the heart between the breastbone and the spine. This extreme physical force manually squeezes the blood out of the ventricles. You release. The chest recoils, the heart passively refills. Push again. In this exact moment, the provider is manually, physically acting as the patient's heart.
It totally blew my mind to learn how we constantly misunderstand this whole process. CPR is absolutely not a cure. It's a desperate, violent physical override. Inside the skull, the basic energy currency of the cells, which is known as ATP, is completely depleting. Cell membranes are tearing open and the brain is actively swelling, turning the rigid skull into a deadly trap. CPR simply pauses this biological clock of irreversible cellular death. It forces just enough oxygenated blood upward to keep the brain from melting down, while the team scrambles to figure out what went wrong. It is purely buying time.
Minute 2. The defibrillator finally arrives at the bedside. Plastic packaging is violently torn open. Sticky pads are slapped directly onto the bare, sweaty chest. The heavy machine powers up with a high-pitched whine, and everyone in the room immediately recognizes the jagged, chaotic spikes appearing on the glowing monitor. That squiggly line isn't just a rhythm, it's the visual representation of millions of cardiac cells screaming in total, uncoordinated anarchy. Now, Hollywood gets this next part wrong literally all the time, and understanding the reality is fascinating. A lot of people think a shock restarts the heart, kind of like jump-starting a dead car battery. It doesn't. A massive surge of electricity is meant to stop everything instantly. Every single chaotic cardiac cell is depolarized, meaning it's stunned into absolute, perfectly still silence. It is exactly like ripping the power cord out of a completely crashed computer, praying that the heart's natural biological pacemaker wakes up and takes back control when the system comes back online. Clear. The button is pressed. 200 joules of raw electrical energy are delivered. The patient's chest violently arcs off the bed. The monitor spikes, and then it might briefly become completely flat. While this sudden flatline often panics medical students, experienced clinicians totally expect it. The heart has just been electrically wiped clean. But here's the brutal reality of the room. There is no dramatic Hollywood pause, nobody stares at the screen, nobody waits to see if it worked. Hands immediately go right back onto the chest. The relentless, grueling physical pace of compressions resumes without skipping a single beat. Minute 4. As the extreme physical exhaustion of the medical team deepens, a nurse manages to secure an IV line. Think about how incredibly difficult that is for a second. Trying to thread a needle into a collapsed vein of a dead patient with absolutely zero blood pressure. It requires immense skill. With the line finally established, pharmacological intervention begins. 1 milligram of epinephrine is pushed straight into the stagnant bloodstream. So why epinephrine? Well, if the agonizing chest compressions are the artificial pump, epinephrine drastically improves the plumbing. It causes intense vasoconstriction. It severely clamps down and tightens the blood vessels in the arms, legs, and abdomen. It effectively sacrifices the limbs, shoving whatever tiny, precious amount of oxygenated blood you are manually generating away from the extremities and channeling it directly to the vital organs that will die first, the brain and the coronary arteries. Mid-resuscitation, the tension in the room mounts to an excruciating level. The team faces the ultimate medical mystery. Why did the heart stop in the first place? Because seasoned clinicians know that cardiac arrest is almost never the disease itself. It's usually just the final fatal symptom of a deeper, hidden failure. They aren't just performing CPR, they are actively trying to solve a murder mystery where the victim is currently dying on the bed right in front of them. While maintaining the exhausting rhythm of compressions, the physician rapidly cycles through a differential diagnosis out loud. Is it hypoxia? Did his lungs fail and he just ran out of oxygen? Hyperkalemia? Has his blood turned highly acidic, poisoning the heart's electrical grid? Is there a massive pulmonary embolism, like a giant clot strangling his lungs? Or is it an acute myocardial infarction, a fully blocked artery? Finding this exact root cause in real time amidst all the shouting and alarms is what truly dictates if this patient will survive the night. Minute 8. The physical toll on the room is immense. Compressors literally have to rotate out every 2 minutes because human muscles simply fail. Sweat drips from foreheads onto the bed sheets. Arms burn and ache uncontrollably. Effective chest compressions are brutal, deeply traumatizing work. You will absolutely hear the distinct, sickening pop of ribs cracking under the immense physical force. But listen to me, the medical team cannot afford to be gentle. In this room, broken ribs are vastly preferable to death. Then, something changes. The provider glancing at the monitor speaks up. The chaotic, jagged squiggles have actually begun to organize into a tight, recognizable pattern. The team leader orders a halt. Compressions stop. An eerie, heavy silence falls over the room. 1 second goes by. 2 seconds. Fingers are pressed deeply into the neck, waiting, just praying for that subtle, mechanical thump of life against their fingertips. And someone quietly says, "I have a pulse." ROSC, return of spontaneous circulation. It's a critical, monumental victory. The patient's own myocardium has miraculously resumed effective pumping. You can physically see the subtle, incredible return of pink color to previously gray, ashen skin. The monitor begins alarming with a steady, life-giving rhythm, confirming blood pressure has actually returned. Now, the battle isn't completely over, but in this exact moment, death has been physically pushed back out of the room.
What is truly awe-inspiring, and frankly a bit surreal, is the aftermath from the patient's perspective. Think about it. Their body was an absolute battlefield. Ribs were broken, veins were punctured, the heart was repeatedly shocked with hundreds of joules of raw electricity. Yet most survivors feel absolutely nothing at all. Some report hearing distant, echoing voices or feeling entirely detached with highly fragmented memories. But the vast majority will awaken hours later in the intensive care unit, terribly confused, with absolutely zero memory of the violent, exhausting, life-saving interventions they literally just endured. It really makes you step back and look at the intense reality of what a code truly is. It's an all-out, violent, minute-by-minute race against time, a race between irreversible cellular death and the medical team's sheer physical endurance to restore circulation. The margin between permanent brain destruction and getting a second chance at life is razor thin and is decided entirely by human hands, split-second pharmacology, and absolutely refusing to stop compressing. A code isn't just about pushing drugs and firing defibrillators. It's a profound, terrifying story unfolding simultaneously in 3 distinct places. Inside the electrical chaos of the failing heart, inside the rapidly suffocating tissues of the brain, and inside the tiny hospital room, where a team physically goes to war against the clock. It really makes you reflect on the incredibly fragile, interconnected biology of human life. We rely on our hearts to beat 100,000 times a day without a second thought. But if it stops, would you have what it takes to step in and physically be someone's heart?